Hi, my name is Andy Duker, and I am the director of the HDSA Center of Excellence at the University of Cincinnati Gardner Neuroscience Institute. I'm really happy to be here today to talk to you about the basics of Huntington's disease, what we've chose to title HD 101, a primer on Huntington's disease. In this presentation, we're going to go over some of the history of Huntington's disease, the symptoms, the treatments, and the hope for the future. So what is Huntington's disease? Well, is it a genetic abnormality on the short arm of chromosome 4 that is inherited in an autosomal dominant fashion that causes neuronal cell loss in the caudate and the striatum, leading to atrophy and widespread dysfunction of critical brain circuitry? Well, that's what I was taught in medical school. But what is Huntington's disease really? Well, really, I think of Huntington's disease as a family of connected people, related and otherwise, joining together to be with one another, to support each other, and to care for each other. And really, in order to understand Huntington's disease, I think that we have to understand its people and understand their stories. So where's a good place to start? Well, the story of George Huntington is a good place to start. George Huntington was born in 1850 in East Hampton, New York. His father, George Huntington Sr., was a family physician, and his grandfather, Abel, was also a family physician on Long Island. As a child, George rode along with his father to see patients in their home. They made house calls back in those days. And George later remembered, when he was 8 years old, that his father was going on a visit to see patients. He stopped the carriage in the road to speak with a mother and her daughter, who were both suffering with abnormal involuntary movements, which we now know as chorea. Over time, he started to see more patients with this condition with his father, and he realized that it ran very strongly in the families that had it and was a genetic condition. He began to take notes on this condition to try to learn more about it, and it was very interesting to him. After he graduated from medical school in 1871 from Columbia University, he started his practice. And soon after that, he moved to Pomeroy, Ohio, which is actually very close to where our center is located in Cincinnati, Ohio. And he presented the observations that he had been working on to the Meigs and Mason Academy of Medicine in Middleport, Ohio, on February 15th, 1872. His presentation was entitled On Chorea, and in his presentation he discussed many of the causes of chorea, including some of the more common causes like Sydenham's chorea and others. But at the end of his presentation, he reported on the familial chorea that he and his father had seen in the families of Long Island. Huntington's presentation was very well received, and he was later invited to publish his findings in the Medical and Surgical Reporter of Philadelphia on April 13th, 1872. And this is a landmark paper in Huntington's disease history. In it, Huntington wrote that the name chorea is given to this disease on account of the dancing propensities of those who are affected by it. If the patient attempts to protrude his tongue, it is accomplished with a great deal of difficulty and uncertainty. The hands are kept rolling, first the palms upward and then the backs. The shoulders are shrugged. The feet and legs are kept in perpetual motion. The toes are turned in and then everted. One foot is thrown across the other and then suddenly withdrawn. Later, a famous physician by the name of William Osler noted that in the whole range of descriptive nosology, there is not, to my knowledge, an instance in which a disease has been so accurately and fully delineated in so few words. Because of Huntington's published description, this was not the first description of Huntington's disease, but it was the most detailed. The disease became to be known as Huntington's disease. So where does the story go from here? Well, Americo Negrete was a Venezuelan physician who identified a large concentration of patients with Huntington's disease surrounding the Lake Maracaibo area in the 1950s. And this was later determined to be the largest single population of Huntington's disease in the world. One of his students, Ramon Avila Garon, in 1972, which was 100 years to the day after George Huntington presented his paper on chorea, Ramon presented video recordings of these patients at the Huntington Centennial Symposium in Columbus, Ohio, which was organized by the World Federation of Neurology. At that convention was Nancy Wexler. And Nancy Wexler was a psychoanalyst whose mother had Huntington's disease. And the Hereditary Diseases Foundation was started by her father, Milton, to help to connect Huntington's disease researchers. Nancy heard the presentation about the HD population in Venezuela, and she became very excited. She organized the first of many annual scientific expeditions to the Lake Maracaibo region. And the information collected during those visits ultimately led to the mapping of the HD mutation to the short arm of chromosome 4 in 1983, and then eventually the gene for Huntington's disease was discovered in 1993. So what does this mean for the genetics of Huntington's disease? How does the HD gene that we've discovered cause Huntington's disease? Well, thinking back to biology class in high school, we remember that DNA sequences are codes to make proteins for cells of the body, in this case, neurons of the brain. Each group of these base pairs is called a codon that translates to an amino acid, which is a building block that makes proteins. So the HD gene encodes a protein that has been called, interestingly enough, Huntington, and the code to make that protein requires the amino acid glutamine. Glutamine is encoded with the base pairs CAG. And in the normal Huntington gene, the code for glutamine repeats CAG, CAG, CAG numerous times, but not more than 26 times. If the number of CAG repeats is higher than 26, what the Venezuelan study discovered, that individual will develop Huntington's disease. We believe that it's because the extra glutamines cause a misfolding of the normal protein, but to be honest, there's a lot of confusion and controversy as to how the extra repeats lead to Huntington's disease. There seems to be an inflection point after 40 which causes the disease. Between 35 to 39 repeats, it's called a gene with reduced penetrance, or a gray zone, which means that the individual may or may not develop Huntington's disease, but if they do, it's usually at an older age. For instance, I care for a patient who developed symptoms at age 78, who had 39 repeats. If the repeat number is between 27 and 35, the person themselves will not develop Huntington's disease, but the gene could expand in future generations so that their children could be at risk of getting 40 or more repeats and therefore Huntington's disease. In general, the repeat length can expand from generation to generation. That's a phenomenon that's called genetic anticipation. And that expansion is particularly common when the gene is inherited from the father. However, the number of repeats can stay the same or even can contract. So it's quite variable. So do higher numbers of repeats lead to more severe Huntington's disease? Well, the answer to that is not really. Having more repeats doesn't necessarily mean that the Huntington's disease is going to be more severe. However, on average, the higher the number of repeats, the lower the age at which the first symptoms are noticed. So look, there's a very wide range of ages for any particular repeat length, however. So if you take the typical repeat length between 40 and 50, that can have an age of onset anywhere from the 20s to the 80s, although most people develop symptoms in their 40s or 50s. Large research trials, such as one called Enroll HD, which many of the Huntington Study Group sites are participants in, have identified other factors, genetic and otherwise, that modify the age of onset. And the hope is that by understanding these modifying factors, new therapies could be developed. So once the gene was identified, people with a family history of Huntington's disease could have a blood test that would tell them if they would develop Huntington's disease in the future. This obviously is not a decision to be taken lightly. Right now, we do not have a way to stop or prevent the disease. So Knowing this future information could be really helpful to some people, but really harmful to others. It depends on the person. To help with the testing process, HD centers have what's called predictive genetic testing clinics to help to counsel these patients. We have a team of providers, including a neurologist, a genetic counselor, a social worker, and sometimes a psychiatrist. And the goal is to provide information to the person so that they can make an informed decision as to whether the testing is right for them. It's important for the person to understand what kind of positive thing they would do with this information, whether it's positive or negative. Some people want the information for planning, for instance, family planning or children, financial planning or career planning. Others just need to know. They can't deal with the uncertainty of not knowing. But deciding to be tested is a very personal decision, and there's not really any right or wrong reasons, and it's not right for everyone. When a patient comes for predictive genetic testing after full counseling about the options, a neurologic exam, meeting with the genetic counselor and social worker, if the patient decides to proceed, they can have the blood drawn, and then they will return several weeks afterwards for the results along with a support person. The job of the Huntington's clinic is to help the person through this process, no matter what the results. So how common is Huntington's disease? Well, some estimates suggest that in the United States and Europe, the prevalence of diagnosed Huntington's disease is between 5 to 10 per 100,000 people. That would translate into about 30,000 people with Huntington's in the US. However, large studies of genetic information in the general population suggest that the HD gene may be more common than this, maybe up to 1 per 2,500 people, which would translate into about 40 per 100,000 people, or 120,000 people in the US. And this number could go up if you include people in the gray zone. So what are the symptoms of Huntington's disease? Well, it's important to know that they're different for every person. Not one person is the same. If you know one person with Huntington's disease, you know one person with Huntington's disease. But in general, the main symptoms involve three areas: abnormal movements, behavioral difficulty, and cognitive difficulty. So why don't we go over each of these separately? So the hallmark movement symptom of Huntington's disease is something called chorea. That is the medical term for the involuntary wiggly movements that are not under the patient's control. In fact, many times the patient's not even aware of these movements. Dystonia is another movement that can be seen, which refers to twisting of the extremities or abnormal postures. Bradykinesia is the medical term for slowness. And this can result in a slowing down of the actions of the person with Huntington's. There can be coordination problems. A phenomenon called motor impersistence is the reason why some Huntington's patients have trouble maintaining their grip on an object, and that could make them prone to dropping things, for instance. Or they might have inconsistent pressure, for instance, on the gas pedal, causing a car to go faster or slower. Balance and walking difficulty need to be monitored closely, as there can be a risk for falls. Dysarthria is the medical term for speech difficulty, which can be slurred or sometimes difficult to understand. And dysphagia is the medical term for swallowing difficulty, which can lead to choking. So how do we treat the movement symptoms of Huntington's disease? So it's important to know that not all the symptoms require treatment. For instance, chorea is not always bothersome to the person themselves, and if it's not interfering with their normal tasks or causing injury, it's not unreasonable to simply monitor it. However, sometimes chorea can cause functional difficulty, and it can be socially embarrassing. So there are medicines that can be helpful for it. We prescribe medicines like neuroleptics or VMAT inhibitors, or other medicines that can help to reduce or dampen the abnormal movements. It's important for the neurologist and the patient and the family to work together to determine which medicine works best for a specific situation. It's also important to know that over the course of the disease, chorea can decrease and become less of a problem. So there may be less need over time for anti-chorea medicine, and that should continue to be evaluated in conjunction with the team. So medications are only one of the ways that we have to treat Huntington's disease. Physical activity and exercise are really important ways to keep the body healthy and to be able to deal with Huntington's. Physical and occupational therapists, particularly those with experience in HD, can work with the patient and their care partner to develop activity regimens that keep patients strong and safe. Speech therapists can work with swallowing and speech issues to help improve symptoms. It's even possible that exercise could slow the progression of certain neurodegenerative conditions over time, including Huntington's disease. So exercise is something that we recommend to every single one of our patients. What are the behavioral symptoms of HD? Well, depression is one of the main symptoms. And depression is not characterized just by sadness about having the disease. Depression is a cardinal feature of the disease, and it's related to changes that are going on in the brain chemistry. HD patients can also suffer from other behavioral problems like apathy or anxiety, sometimes irritability or mood swings. There can be obsessive or compulsive symptoms and sometimes impulsiveness. This impulsiveness, along with the depression, can lead to an increased risk of suicide. This is a very important symptom to monitor for and should always be taken seriously. It's important to know that the behavioral symptoms of Huntington's disease can be under-recognized. For instance, depression doesn't always mean that a person is sad or crying, but it could present as just trouble sleeping or anxiety, or even pain or anger. The irritability and impulsiveness of the disease could lead to mood swings and sometimes behavior that's unsafe. So the patient and the caregiver need to have a low threshold to ask their team for help in these situations. Fortunately, we do have good treatments for the mood and the behavioral symptoms of Huntington's disease. Depression can be helped by antidepressant medications, like the SSRIs, for instance. These same SSRIs can sometimes be useful to treat anxiety or sometimes used to treat compulsiveness. For irritability or mood swings, we can use some other of the neuroleptic medications as well. Meeting with a psychiatrist or a psychologist, ideally with experience with HD, can be helpful. This can provide an outlet for the patient to discuss the feelings that they're having and an opportunity to discover constructive ways to handle the issues that are facing them. Therapy can also be important for the care partner. It's critical that the care partner take care of themselves as much as the patient. Establishing a routine of activities that is consistent during the day can help with apathy and anxiety. If the brain knows what to expect, there's less stress. With regards to irritability, if the family can find out what might be triggering these feelings, it can lead to less outbursts or meltdowns. It's important to know that because of the way that HD affects the brain circuitry, it can affect the patient's ability to reason and understand things. So trying to explain and convince a person why they should do something can be counterproductive, and you may need to pick your battles. So what are the cognitive symptoms of Huntington's disease? Well, when we think about cognitive changes, we think most commonly about memory. Memory is not affected in Huntington's disease in the same way that it's affected in Alzheimer's disease. For instance, Huntington's patients have more trouble retrieving a memory than getting it in there in the first place. Whereas in Alzheimer's disease, they have more trouble with getting the memory in the first place. So, for instance, if you give a list of words to a Huntington's patient and then ask them what those words are later, they may not be able to give you those words. But if you give them a list of a lot of words, they're going to be able to pick out the ones that were in the list that they were given initially. This can lead to ways to help with their memory, which we'll go over a little bit later. Huntington's disease can cause problems with emotional awareness and recognition, which can lead to problems with relationships and is important to be aware of. There's a phenomenon called anosognosia, which is a medical term that means that a patient is unable to see the problem because it's happening to them. And so an HD patient may have chorea, or they may have fine motor difficulty or decreased reaction time, but they may not be aware of it. And so this makes it very hard for an HD patient to understand sometimes why, for instance, they're not able to drive or not able to do the same job. People can have what's called perseveration or repetitiveness that can cause them to repeat the same thing over and over. They can have poor attention, and they can have problems with executive dysfunction, which is the medical term for difficulty with, say, following directions or completing a list of tasks or multitasking. So unfortunately, the medicines that are used for treating the cognitive symptoms in some other diseases, for instance, Alzheimer's disease, they're not helpful for treating the cognitive issues in Huntington's disease. There are several medications that are under investigation in clinical trials, but at this time, we don't have a medicine that can help cognition in Huntington's. And this is a area of HD treatment is a major unmet need and can be quite challenging for the patient and the family. However, that doesn't mean that we don't have options to help. There are always ways that we can find to help to reduce or improve symptoms. For instance, remember that an HD patient can remember things if they're given a list. So using a to-do checklist can help someone draw into that memory and retrieve it and provide the means so that they can do more things on their own. In the same way, if a person is having trouble remembering something, giving them cues can help them remember it. Routines can be really helpful. I think of routines as like scaffolding or structure that can help to reduce the uncertainty and allow the person to know what to expect with less stress. Remember, less stress equals better function. So to summarize, we've gone over a lot about Huntington's disease, its history, the genetics, the symptoms, and the treatment. It's important to remember that the treatment of Huntington's disease requires a team approach with a wide array of specialists and consultants, but the patient and the family are at the center. So what is Huntington's disease? Huntington's disease is hope. Hope for the present, hope for the future, and a way forward as a caring team. Thank you for listening, and now I'll be happy to take your questions. Hello. Hopefully you guys can all hear me. I'm Andy Duker, and so that was a recorded presentation. Obviously, I did not change ties and run from my office back to my house quite that quickly. But I'm here today live to help give some questions and answers to any questions that you have. So please feel free to type those questions into the purple question and answer box, and we'll try to get through as many as possible. I'm really glad that you're all here today to learn more about Huntington's disease. I think this is the important critical step towards finding ways to live well with this disease, is to educate yourself. So thank you for attending. Let me look through some of the questions here. There's one question that asks about how to seek help, right? So if you don't live close to, say, a Huntington's disease center of excellence, how can you get access to all of those specialists listed on the slide? How can you get access to that multidisciplinary level of care? And I would advise you certainly to talk with your neurologist, or talk even with your primary care doctor. They may not be experts in Huntington's disease, but if you don't have a Huntington's disease expert close by where you live, you can kind of become the Huntington's disease expert yourself, right? These are symptoms that are happening to you. These are symptoms that you can help educate your family doctor. I can't tell you how many of my patients come and tell me that they've been able to educate their primary care doctor about Huntington's disease and really gotten better care because of it. And so take the pieces of the puzzle and help construct them for yourself if you need to. Certainly, it's never a bad idea even to make a trip to a Huntington's center, so they can check in with you and get a sense of if there's anything else that needs to be done. But for regular care, you can help to use the resources that are local to you. Let's see, some other questions. So let's see, how does Huntington's disease break out in terms of numbers by race? That is a good question. A lot of the data that is looked at in Huntington's disease epidemiology is US-based, but we're getting much more information from the Enroll-HD study, which is, if you're not familiar with Enroll-HD, it's an observational study that is worldwide, has over 20,000 participants in the study. And it is collecting both demographic data as well as genetic and other biomarker data to help understand Huntington's disease more. And so that's given us a much better sense from not just the US, but also Europe, Latin America. There's sites for Enroll-HD throughout the world. And so that's, I think, giving us a much better sense of things. It doesn't seem in the US, the breakdown is more along familial lines than racial lines. And so I think that's probably the answer to that question. Let's see. So one question came through, how do doctors assess the progression of Huntington's disease? How do they track it over time? What can you expect when you come to the doctor? Well, the most common way to assess Huntington's disease is by looking at the symptoms of the disease, right? By talking to the patient, talking to the family, trying to really understand what they're going through. To look at these things in a standardized way, the Huntington Study Group actually developed the UHDRS, the Unified Huntington's Disease Rating Scale, and that tracks symptoms across 4 different domains. So motor symptoms, cognitive symptoms, behavioral symptoms, and functional capacity. And so when you're looking at motor symptoms, these are sort of simple motor tasks like tapping your fingers or flipping your hand over and back, or more complex motor tasks like a series of events or series of tasks. Walking, an assessment of your balance, an assessment of involuntary movements or chorea. The cognitive assessments are really fun tests, like trying to tell the color of a word, like for instance, the word green when it's printed in red ink, and so other interesting tests like that. There are behavioral tests, which are mainly questions about a person's mood and behavior and things like that. And then the functional assessment looks at, how are you doing on the things in your daily life? What are you able to do great without any help? What are some of the things that you might need a little more help with, like, for instance, working or doing the laundry? Now, it's important to know that these questions are what you could do, not what you actually do. So can you do the laundry is probably a different question than do you do the laundry? But by tracking these symptoms over time, you can help your doctor to understand where are the problems, where are the hot spots, what can we focus our energies on and to try to help you. Are there medications that need to be adjusted, things like that. So these are some of the ways that you and your healthcare team can help to track your symptoms over time. Let's see. So one question about the gene tests came up. It says, my primary care doctor ordered a predictive gene test and just called me with the results. Is that okay? That's a complicated question. Honestly, the HDSA has set forth a series of guidelines for the predictive testing of Huntington's disease. And really the assessments ideally have been traditionally in person. There is a movement, and we've talked about this as a research and as a clinical care community, about whether genetic counseling and testing can be done, say, over a video visit or through the internet. And I think that's evolving. But in general, if you're thinking about predictive testing, I would strongly encourage you to look at centers that have a multidisciplinary team to provide the support, to provide the education about the whole testing process. You need to have a support person with you. You need to have a team in place so that they can help you ask questions about the process and that they can be there to support you, whether the test is positive or negative. Both outcomes require a fair amount of support. And so really the testing works best, and it's traditionally done in person. We really suggest that phone relaying of the results is probably not the best idea. Let's see, some other questions. I've heard that the CAG repeat number gets bigger as you get older. Is that true? That is some of the newer research in Huntington's disease, and that's one of the thoughts towards potentially slowing the progression of Huntington's disease over time could be a way to stop that progression of the CAG repeat number. I would refer you to the presentation on what's new in genetics in Huntington's disease by Matt Bauer. He's going to talk about that specific question, so I would encourage you to listen to that talk. Someone asks, would you talk about some of the treatments being tested for cognitive changes? Yeah, so there are a number of tests, a number of studies being looked at for new medications for the cognitive changes in Huntington's disease. I know that Sage Therapeutics is looking at one, and there's also a trial in the works from the Neuronext group that is a consortium of academic research centers across the country looking at a different compound. And so the hope is that we can develop a therapy that will directly affect the cognitive symptoms of Huntington's disease themselves. And I think we'll know more once we have the results of those trials. I had a question that asks about the perseveration that we talked about, that sort of getting fixated on something. Sometimes that can result in repeating the same thing over and over, but sometimes it can result in sort of compulsive activity, like the question asks about, does fixation, like on religion, seem like an obsessive compulsive symptom? And certainly that can be, right? So a person with Huntington's disease, their their brain circuitry isn't working at top capacity, and so they may have a thought, and that thought kind of gets stuck in a loop in their head, and that kind of keeps going over and over. And they may say it out loud, or they may be thinking it repetitively, and through no fault of their own, that's something that they can't get out of their head. And so hyper-religiosity is something that we can see. It's important to talk to your doctor about those kind of symptoms, because those are symptoms that we can help both either with a medication or through talking with a psychiatrist or psychologist about the symptoms that you're having. Those can both be addressed. Let's see. I've been kind of skipping around here on the questions. Thank you for sending in the questions, but please keep sending more in if you have any. Let's see. One other one that I had, here it is. You mentioned exercise is important in Huntington's disease. What kind of specific exercise is most helpful in Huntington's disease? Well, there haven't been head-to-head studies of specific exercises showing that this exercise is better for Huntington's disease than this exercise. It seems to be a class effect. It seems to be the fact that you do the exercise is more important than what exercise you're doing. Recommendations that I give to my patients, I ask them, what do you like to do? So if you like to golf, golfing can be a good exercise. Do you like to walk outside? Walking is an excellent exercise. How about a stationary bike? Stationary bikes are great because even if it's cold outside, you can get the exercise inside. What about yoga? There's an excellent presentation that's available on demand that you can go to the theater and look at about yoga in Huntington's disease. These are all great options. What about if you're having more trouble getting around? What about active range of motion exercises? So stretching exercises, and even for people who are having more difficulty, a caregiver can provide passive range of motion exercises, so moving the arms and legs for your loved one. Ultimately, the key is just to find something that you like to do, that you can do regularly, that you can commit to do regularly. That's the key. So finding a group of people can be a really great idea, or to exercise with a care partner. It's really easy to lose momentum when you start an exercise program, and sometimes you need that push to keep doing it regularly. All right. Anyway, I think we're nearing the end of our time. I'll give you a few minutes to hopefully go over to the yoga presentation and look at that, or go to get a bio break. We have more exciting sessions coming up starting at 11:45 with the presentation I talked about by Matt Bauer, the Huntington's disease, what's new and what's not, as well as a different one, the complementary and integrative medicine approach by Danny Vega, which I'm really excited to hear about as well. Both of those are excellent. Remember that if you you don't necessarily, you have to choose in terms of what to watch live, but all of these sessions will be available and you can go back and watch them, so don't feel like you have to watch them simultaneously. Well, great. It's been really an honor to talk with you guys today, and I really appreciate the chance to go over Huntington's disease, and I hope that you have a great rest of the day, and thank you for coming to learn about HD.